Well, hello, and once again, a warm welcome to this month's podcast. And as always, we're going to bring you up to date with the very latest data in the wonderful world of rheumatoid arthritis. So, in this episode, I'm going to be reviewing papers by Gert Bemmerster and Kevin Winthrop. And they have been seeking to characterize the safety profile of upadacitinib across multiple approved indications. I'm hoping we'll also get some insight into long-term use, particularly to inform clinical decision-making and evaluate immunogenicity of the recombinant zoster vaccine through week 60 in people with rheumatoid who were receiving upadacitinib 15 milligrams once a day and a background of methotrexate. So these are really quite clinically relevant practical papers that we're looking at in this particular podcast. And as ever, if you want to look at deep summary slides for the papers I'm talking about, pop along to imidforum.com. That's imidforum, all one word, .com. Okay, so first paper, safety profile of upadacitinib, a descriptive analysis in over 27,000 patient years across rheumatoid arthritis, psoriatic arthritis, axial spondyloarthritis, atopic dermatitis, and inflammatory bowel disease. Well, all of us know that the JAK inhibitors are now being used across multiple indications in the IMID field. We have seen an increased risk of adverse events, as one would expect of any immune modulatory drug class. And in addition, there are safety concerns raised around JAK inhibitors following the oral surveillance study, which we've talked about many times before in this podcast series. And a quick reminder, upadacitinib is an oral, selective and reversible JAK inhibitor, and it's been approved now for use in multiple immune-mediated diseases. Gert Bemmerster and his colleagues characterised the safety profile of upadacitinib across multiple approved indications and have given us some insights into clinical decision making. And that's what this paper was really all about. So the most frequently reported treatment emergent adverse events included COVID-19, think about the time frame in which this study evaluation took place, upper respiratory tract infection, nasopharyngitis, herpes zoster, UTI, acne, primarily in patients with atopic dermatitis. Serious TAs range from 4.5 in atopic dermatitis to 11 in ulcerative colitis, and those leading to discontinuation ranged from 2.9 in patients designated ANG-SPOND to 8.3 in those with ulcerative colitis. TAs leading to death ranged from 0 in the non-radiographic AxSpA UC group to 0.7 in the rheumatoid group. Okay, a lot going on here. Amongst the UPA-treated patients across indication, rates of the AESIs were 1.3 to 4.6 for serious infections, 2.4 to 6.6 for herpes zoster, no great surprise there, 0.2 to 0.9 for malignancy, excluding non-melanoma skin cancer, 0 to 1.4 for non-melanoma skin cancer, 0 to 0.5 for MACE, 0 to 0.9 for venous thromboembolic events, and 0 to 9.2 for an elevated CK. Interestingly, in RA and PSA, herpes zoster, non-melanoma skin cancer, and elevated CK rates were numerically higher with UPA versus active comparators. Now, serious infection, herpes zoster, malignancy, excluding NMSC and NMSC per se, MACE, and venous thromboembolic rates were stable over time. Okay, there's a lot going on in this paper. I actually suggest you do pop across to the website and take a look at the data in detail just to refresh your memory, but it's good to have them all in one place for the clinical consult side of life. It's a descriptive analysis. It contains a lot of long-term safety profile data. It's consistent with what we've been reading about over the last 3-4 years. And I think in general, it supports the ongoing use of upadacitinib in these diseases. No real surprises. As ever, we need to be clinically vigilant, and as ever, we need to make sure we pay attention to the black box warnings that are guiding our use of these medicines across a variety of diseases. Okay, second paper I want to cover is about immunogenicity of adjuvanted recombinant zoster vaccine in patients with rheumatoid arthritis treated with upadacitinib. These are 60-week results from a randomized controlled trial sub-study. We know that there's an increased risk of herpes zoster in patients receiving JAK inhibitors, upadacitinib being no exception. And it's really important to optimize patient care and minimize the risk of infections by thinking about vaccination. Now, despite proven efficacy of adjuvanted RZV in preventing herpes zoster in adults, immunogenicity of RZV in patients with RA receiving JAK inhibitors, particularly those on UPA with background methotrexate, hasn't until now been that well studied. So Kevin Winthrop, the great man that he is, evaluated the immunogenicity of RZV through week 60 in patients with rheumatoid receiving UPA, 15 milligrams on a background methotrexate. So key results here, well, 93 patients received both RZV doses. Majority of them were female, mean age 62. At baseline, 49.5% used concomitant steroids, and that median daily dose was 5 milligrams. Always need to remember the steroid dose when we're thinking about vaccine efficacy and vaccine responses. The satisfactory humoral responses to RZV were observed in 87.8% of patients at week 16. Age and concomitant steroids use did not affect RZV antibody responses, so that's good news. And over 6% of patients receiving achieved a cell-mediated immune response to RZV at all time points. No SEs were reported. One patient developed herpes zoster 4 months after the second RZV dose. So the key conclusions here, well, in this study, most patients vaccinated with RZV on the background of upadacitinib 15 and methotrexate achieved quite satisfactory humoral and cell-mediated responses to RZV at weeks 4, 16, and 60. As ever, factors such as age, severity of disease, and use of dose or dose of concomitant steroids somehow on this occasion didn't greatly affect humoral responses, so that's interesting, but always something to bear in mind when you're in clinic. The vaccine itself was well tolerated, no SEs reported within 30 days following vaccination, but remember this is a small study in terms of vaccine exposure. And overall vaccine efficacy would require far greater numbers. There is an element of observation about this. And they do, however, I think support the use of RZV as an effective long-term preventative strategy. So please think about vaccination, and please particularly think about the recombinant vaccine, and be reassured that you can tell your patients it doesn't look as if background upadacitinib 15 mg on a methotrexate base will have any significant impact on the likelihood of the vaccine being beneficial. So that's great. Okay, well, look, as ever, to look at these papers in more detail and a few other publications we've uploaded this month, head across to imidforum.com. You'll also find other podcasts and resources there. They're free for you to use. And as I often say, a Scottish guy rarely offers you something for nothing. So on this occasion, go across to the website, see what's there. I hope you enjoy it. And don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel, just to make sure you don't miss any of our podcasts in the future. How could you think of such a thing? And as always, make sure to let us know what you think by leaving a review. So as ever, wishing you the very best for your patients, and thanks so much for joining me and giving me your attention. Take care.